Hi everyone, I'm Julia Sadar and I'm going to be part of the RAD conference today. I'm a senior psychological minor and I'm going to do a presentation on the current use of the Diagnostic and Statistical Manual of Mental Disorders, more commonly known the DSM. So for the past 3.5 months or so, I've been writing up my thesis as part of the Scholars Program regarding the use of the DSM-5. And what I wanted to find out and investigate is how psychiatrists use the DSM-5 on a day-to-day practice. And also I wanted to find out how the recent changes back in 2013 have impacted their treatment plan and diagnosis. So first of all, I'm going to give you a little bit of history when it comes to the DSM and why it was created. It was created as a result of war veterans for the Vietnam War, as they had, a lot of them had PTSD, what's known as post-traumatic stress disorder. And the manual was a response to that because doctors didn't really know how to diagnose it and how to treat it. So the DSM came as a response to that. And you'll see that throughout history, the DSM, and when it's been revised and evolved, that it really was a response to societal needs. So as you can see, it was created in 1952. That's when the first DSM was first created. And then in 1968, we had the DSM-2. The DSM-2, basically in the DSM-1, you had only 50 disorders. In the DSM-2, you already had 96 disorders. So you saw that throughout history, people and their knowledge on mental disorders evolved, therefore disorders, it went up, like the level went up. So then in 1974, actually, it was a response to a societal change because of the sort of gay human rights in the States. Homosexuality was regarded as a mental disorder up until that point. And so in 1974, they had to take it out of the DSM. And so that's why it's in 1974 that they actually made the revision, because they wanted it to reflect society and not just be this old manual that only psychiatrists would use. In 1980, as a response to the evolution in science, the DSM-3 was first published. In 1987, it was a revision, and here you kind of had a whole idea behind brain and CTs and MRIs and so on that really evolved. So they really had to sort of go away from contextualizing disorders and really sort of understand the criterion behind a mental disorder. Later on in 1994, they did the DSM-4. This is the DSM that kind of has the most praise. People really all agree and love this manual. So I think this is to keep in mind with what happened later on, because they revised it later on in 2000, and that really sort of gave the medical community more of a divided outlook, because people thought that the personality disorders, for example, the section in the DSM, was too reductionist. So there were already kind of criticisms kind of rising up below the surface. So it's with no surprise that in 2013, when the DSM-5 was first published, not too long ago, they took out the Roman numerals, but they also took out a lot more. And it has a lot of meaning for people in the psychiatric and medical community, as it really was a big change in terms of the way diagnosis was performed. So I'm going to sort of go through the actual thesis and how I went about it so that you have a better idea of what I did. So first, looking at the introduction, why am I doing this? What's crucial? It's a tool that's used every day, and psychiatrists see it as a Bible. They see it as this manual that they refer everything to, not only for their patients, but for insurance companies, for reports, for research. So it's a tool that is crucial in the medical community and has become a worldwide phenomenon. So I believe personally that by investigating the tool, we'll find out a lot more about how people and how the medical community uses it. So that was why I wanted to investigate that. Now, I wanted to do it in a qualitative type of study. I wanted to really engage with the people behind the study and not just do a literature type review. And so I think it gave me more kind of feedback and really helped me move forward in the research. And I wanted to know more about how psychiatrists in the Geneva region use the DSM. And as I'm in the Geneva region from Webster, Geneva, I wanted to see how they use it and how day-to-day practice have evolved from the change in 2013 with the DSM-5. So going back to methodology, I did one-to-one interviews. They lasted about 20 to 25 minutes, and I really wanted to just investigate how they use it. I wanted to know more about how they understand the manual, how it helps them, stops them sometimes, how it has pros and cons, and I really wanted to know more about that. And I'll discuss the results a little bit further along. I interviewed 4 psychiatrists. 3 are part of my thesis, 1 was a trial run, and I know the number's very tiny, I know that. And I know that for statistics it needs to be at least 30 people. But I think it gives you an idea, and it gives you a sense of where research could go. So even if it's not statistically relevant, I think that you get feedback from what people said, and it can give you ideas of what to do in the future. So the results. Obviously, I'm still in the process of writing the final conclusion because the thesis will not be due for another 2 to 3 weeks. But already I can see that people find the new DSM-5 as reductionist. And I also focused on 2 areas of the DSM-5 in terms of study. It's the Autism Spectrum Disorder, which is a new spectrum that they've created for the DSM-5. And I have seen that they have took out Asperger syndrome, which is something that the medical community are frowning on because they consider it to still be a disorder to this day, and it has given them issues with insurance companies. So that's something actually that came up, not by my asking, but by simply the psychiatrist's own feel of the manual and their own personal experience. So they realized themselves that when they had a patient that has Asperger's, when it came the time to actually write up a report for insurance companies, they had issues because it wasn't there. So they had to sort of use this tiny little segment that's in the manual that says that you can use your own experience. So this is kind of a sentence that they added to protect people who had Asperger's and who still are going to have Asperger's to still fall under the criterion in order to be covered by insurance. So that's one of the main issues that has come up in those interviews. Another issue is regarding the personality disorder section. I'm giving you a simple example to give you an idea, even if you don't know anything about psychiatry. When a manual of diagnoses goes from 28 pages for borderline personality disorder to 7 pages after one revision of a manual, this gives you a sense of how much was lost in the making. And I'm not saying that the entire DSM is terrible at all, not at all. It's a really beautifully written manual. However, I am shown by the medical community and by my research that there are gaps and that they should be revised, and we should include contextual factors for those mental disorders because it gives us a lot more information, especially in regards to diagnosis. So those were the results that were sort of the most important ones that really I think should be shared now. Now, in terms of the discussion and what should be done and where should we go from there, personally, I'm going to keep researching that particular field because I find it fascinating, and I really want to expand the research to more people and to have even more people interviewing and even more research done. And I personally am very passionate, and I would love to keep working because I think I'm just seeing just the surface, and I really want to just dig more. So in terms of the discussion, there was a dimensional type of trait back in the DSM-3 that was loved by most of the community that I think they should reinstate because they already have it written up. So it wouldn't be too much work, but it would give, for example, for personality disorders, it would give a more contextual aspect to the disorder and to the diagnosis, especially in regards to familial pattern, which have really brought so much light into how the patient deals with their disorder and how it affects the family, how their family and upbringing and environment has shed the light on how they're dealing with the disorder now. So I really think that more should be done, and we should reinstate that dimensional aspect from the DSM-3. So Now, my suggestions, like I mentioned, was for the Asperger's disorder, so I really think that they should reinstate it again. That's what I got from the interviews, especially one psychiatrist that told me that now they just look at the DSM-4 for reference and for their own personal history, and the DSM-5 for insurance companies. And that's something that came with all psychiatrists that I interviewed. They said that they kept the old manual for their personal use and the DSM-5, the current manual, for insurance companies. So I think that speaks a lot on how the DSM-5 has been received in the medical community, and we should remember that and keep that in mind. Like I said, a dimensional aspect, especially in regards to personality disorders, would be really helpful. Finally, the subsections, like I mentioned, familial pattern, contextual, and subcriterion would be just important to have and to discuss. And finally, I think that the key of this study is to suggest that changes and to move away from this sort of checklist of criteria that you need, and just remember this holistic aspect of people and the relationship between the psychiatrist and the patient, and just include that and not move into this checklist type of mentality. Like I showed this picture in particular to show that there's someone behind that checklist, and we should keep that in mind and avoid labeling and criterion-based diagnosis. So finally, to conclude, I would like to say that the findings and limitations of the tool have been interesting to find out, and we need to gather more data. We need to research that even more, even in more detail, in order to really understand and find out how psychiatrists use the DSM. I want to end with a mention of David Kupfer, which is the chairman of the task force of the DSM-5, who said that we should move away from medically based type of diagnosis, and we should have it open and understood by most of us. I disagree. I think that patients who suffer from mental disorders should be diagnosed by psychiatrists or medical community and physicians who know exactly the implications. As again, behind the patient, there's a family. Behind the family, there's a history, and this should always be kept in mind. Thank you very much.